Right. Thank you. Now, good morning, everybody. Mr. Gale, when you're ready.
Thank you very much, my Lord. Good morning. My Lord, there are two witnesses today, albeit that they are going to be giving evidence in different forms. The first witness we have is Henry Simmons, who will be introduced in a few moments. The second witness is Dr. Jennifer Burns. Dr. Burns has provided the inquiry with a lengthy and detailed statement. She is the head of the British Geriatric Society. She is not, however, keen to give evidence orally to the inquiry. So, given that her statement contains a considerable amount of interesting and relevant, in our view, material, it is my intention to read large sections of the statement out. The timing of that is that she will get that read of her statement will commence at 2 o'clock after lunch. So Mr. Simmons will be the only witness this morning. So Mr. Simmons, please.
Thank you very much indeed for that explanation, Mr. Gill. Now, good morning, Mr. Simmons. Thank you very much for coming. Please take a seat and make yourself comfortable. Good. Now, I see you've got some papers. I don't know if you want anything in front of you at the moment. Some statements and stuff. Yeah, that's fine. Very good. When you are ready, Mr. Gill.
Thank you, my Lord. Just for everybody's reference, Mr. Simmons' statement, the reference is SCI WT 0566 and then 501, and it will be displayed on the screen as we're going through. Mr. Simmons, good morning.
Good morning, Mr. Gill.
Could you tell the inquiry, please, your full name?
It's Henry Simmons.
Your date of birth is known to the inquiry, but I think it suffices for present purposes to say you're 56.
Yes.
And you're the chief executive of the charity Alzheimer Scotland Action, which is more easily known, I suppose, as Alzheimer Scotland.
Yes, Mr. Gill.
And at paragraph 4 of your statement, you tell us that you've held that position since 2008, so for the last 15 years.
Yes.
And you were in that post during the whole of the pandemic and remain in that post.
Yes.
Can you tell us a little bit about your background, Mr. Simmons? Before you became chief executive, what did you do?
Yeah, so I'm a registered social worker. I started my sort of career off in the mental health world. I trained as a registered mental nurse in Lanarkshire, and then I worked in London for a period of time, and Leeds for a short period. And then I returned to Scotland to work for a local mental health charity for several years. And I then worked for Enable Scotland for 10 years. And I've only really had 3 big jobs in Scotland since becoming the Chief Executive of Alzheimer Scotland.
Right. And just in general terms, can you tell us what your role as Chief Exec of Alzheimer Scotland involves? Yeah,
sure. So Alzheimer Scotland is a traditional charity insofar as we have a large membership base across Scotland. We really set out to do 3 main things, which is to prevent, cure dementia. And our goal is to make sure no one goes through the experience of living with dementia on their own. My role is the day-to-day running of the charity. I mean, we have at the present time around 400 staff. We provide a number of initiatives that we self-fund through our fundraised income. So we run dementia resource centres, brain health centres. We also, provide a network of dementia advisors, 24-hour helpline. We fund research projects. We fund various initiatives within our NHS, including Alzheimer Scotland consultants, both nurse and AHPs. And alongside that, we are commissioned by Health and Social Care Partnerships to deliver two main forms of commission support. One is post-diagnostic support services, and the other is registered day services or community connection project. Alongside that, my role is to oversee our campaigns, our public policy engagement, all of our communications, and indeed represent the 90,000 people living with dementia in Scotland as well as possible.
Yeah. Now, some of that material that you've just given us is incorporated in your statement in paragraphs 5 and following. Yeah. I think, just to be clear, when you say you have 8,000 members across the country, that's at paragraph 5, what constitutes a member for you? So
a member is someone who signs up to be a member of Alzheimer Scotland. It's not someone that we would be supporting, it's someone that actually is a bona fide member with the rights to vote, obviously, at our annual general meeting and other events.
And you also say that you have 90,000 or over 90,000 dementia friends. Yeah. What are they?
So that's different from obviously our membership. The Dementia Friends programme is a real engagement of people who wish to do something positive to support people with dementia, and we train them in a very small scale way to become a supporter and in some ways just a general sort of like friend towards the dementia movement.
And also you say that you are supported by over 1,000 volunteers. Yes. What areas do volunteers volunteer in?
Yes, I mean, from the very top level of the organisation, our trustees, for example, are volunteers and regarded as such and given their time for free. Our helpline has been in existence now for over, I think, 30 years, and that's run by a team of volunteers. And then we have many volunteers who support our local services and just give extra support on a day-to-day basis for people. And it's quite a broad church of volunteers.
Okay. Excuse me. If we just go on in your statement, I'll take some of this read short. At paragraph 9, you say that we are commissioned for post-diagnostic support services for people with dementia, and now employ approximately 120 post-diagnostic support link workers. Can we go perhaps to pre-diagnostic? Because I think it's something you mentioned subsequently in your statement. So far as pre-diagnostic work is concerned, does your charity have any involvement in that or any particular interest in that?
Yeah, I mean, at the present time, we've been developing a new significant initiative to engage people significantly before they start to develop any form of symptoms of dementia, even through our prevention work and our project called Brain Health Scotland. And over the past probably 10 years, we've learned much more as a dementia community about the potential of prevention, and there are 12 sort of lifestyle circumstances which we now have a very strong universal agreement that if we actually tackle sooner and earlier with some form of personalised risk reduction, we could make a substantial difference towards people developing dementia. So that's one area that we're obviously working in. There is also the area where people who, in the journey towards receiving a diagnosis of dementia, it's a rocky road, Mr. Gale. It's not a smooth process, and people can be, for some time in a position where they might be experiencing some form of mild cognitive impairment or other forms of symptoms. So all of our dementia advisors and helpline and our services will provide people with support at that point. And that's
I'm sorry. And I think one of the points that you make later in your statement, and we'll come to it in due course, is that during the pandemic there were considerable difficulties in the pre-diagnosis stage of dementia?
Without a shadow of a doubt, and I could say more about that just now, Mr. Gill, if you would like me to.
We'll leave it until we come to it in your statement, but I think it's worth flagging up at this stage. Also in paragraph 9, you refer to, excuse me, that you have around 17 registered small-scale day services. Yeah. What are they? So
day services are geared more towards people who are progressing towards the more sort of moderate mid-stages of their time living with dementia. And our approach to that is that you need to develop very specific forms of support for people during the day services that are really required to be small, focused, quite intensive. It's about perhaps someone being with us for a day, participating in cognitive stimulation work, reminiscence work, one-to-one support, general peer support groups. So our services might have somewhere in the region of between 8 to 12 people each day, and the individuals might attend for 2 or 3 days per week. They tend to be commissioned by health and social care partnerships, and they're registered with the care inspectorate as such, so they're registered services. It's different from our community projects that we run in groups, activities that we run on our own, which aren't registered, but these are registered and regulated in that fashion, Mr. Gill.
And are these geographically spread throughout Scotland?
Yeah, I mean, we operate mainly in areas, obviously, where the Health and Social Care Partnership are looking to provide this type of support. Not everyone does. Not everyone is able to commit to small-scale services and have to use perhaps larger environments that we don't do. But yeah, I mean, we operate from Shetland all the way down to the borders and Dumfries.
Thank you. I think you also, and you've hinted at this already, you have a 24-hour free phone helpline. And did that continue throughout the pandemic? Yes,
very much so. I mean, we accentuated our helpline support to really make that our front line during the pandemic.
Yep. And you then say that your link workers, this is paragraph 12, are working with at least 5,000 to 6,000 people after diagnosis each year.
Yes.
And is that cohort of people, is that within the community or within both the community and the care home locations?
The model of post-diagnostic support is primarily based on our 5-pillar model, which is a model we developed probably about 12 years ago, prior to the first National Dementia Strategy. And the essence of it is that we will work with people as early as possible in their journey with dementia. And the earlier and more timely that we can work with people, the more we can do to build their network of resilience and support across their community, the more we can do to actually help people maintain their community connections, social connections, in some cases employment. You know, it's a very, very sort of like early form of intervention that we've really been very proud of, because Scotland was the first country in the world to make this a commitment and a guarantee, and to really give that type of consistent support, albeit we've never managed to achieve it 100% across the country, maybe 50%. But what it does is it really helps people who have been through that rocky journey towards diagnosis to get some choice, power and control back into their life, to start to come to terms with the illness, to understand it, to build up person-centred plans about how they're going to live well with it, to build connections and peer support. And it's a very important part of our system that's all dependent on that link worker role. We have another model, which is for people who are a little bit more progressed, and that's called an 8-pillar model. And often people who are getting a diagnosis are not at that early stage. They need a bit more support and a bit more work. In terms of the care homes, our view is absolutely that if someone gets diagnosed in a care home, they should still receive that same level of support. But what you'll find is that in terms of sort of prioritisation and resource, we've never had enough link workers to deliver the across the whole of the country, and I think a lot of areas who commission that, which would be the health and social care partnerships, gear things more towards the community as opposed to the care home environment, and it is an area that is often discussed, Mr. O'Keefe.
Thank you. I'm just interested, you mentioned, I think earlier, and also again in the most recent answer, the person-centred approach. Would that also include the family and the carers of somebody in early stage and then perhaps a more progressive stage of dementia?
Yeah. When we say person-centred, it encapsulates all of that. And our view is that in order to help someone live well with dementia, you have to look at their whole sort of social system of support, and you have to understand the strengths within that you can build on, and the areas where you might need to put additional supports in. So the family, the extended family, the person's community, the person's sort of, broader networks are the foundations of how you build that person-centred approach. And everyone will need a different form of support at that point, and it will be very sort of individualised, but that's in essence the basis of that approach.
And I think one of the things that I've picked up from your statement, and please correct me if I've got this wrong, but one of the important aspects of the work that you do in relation to supporting those with dementia is to try to establish for them some sort of regular and organised daily routine.
Yeah. For some people, as I mentioned earlier, you could have a 2 or 3 year period which is very traumatic before you receive a diagnosis. So people will start perhaps having difficulty remembering issues. They might have difficulty, with just basic sort of day-to-day, issues about the community, forgetting things, and actually they're really struggling. And will then find their way to a GP. Now, it might take a year or two before they start to get a diagnosis, and during that time, people can often stop doing things. It might be that they don't go to church anymore, or they stop going to their golf club, they withdraw, they get pretty anxious at times. So what we're trying to do is to bring all that back out with individuals, and to then use that community, that strength of community alongside what the person's choices are and what their hopes are, and really, Mr. Gill, to inject a bit of belief that you can live well with dementia at that point. And that's quite a transformation, because 15 years ago, the view was there's no point giving someone an early diagnosis of dementia because there's nothing you can do about it. The general perception, which sometimes still permeates, is that this is a condition that's only about much older people, and it's part of growing older. It's never been properly understood that this is actually a brain disease process which is progressive, and the earlier that you intervene with personalised supports and plans, the better someone can live well. Now, our view is very much that if you give high quality post-diagnostic support to an individual, and I mean high quality, I don't mean 2 sessions or 1 session. I'm talking about a year's worth of really high quality, skilled intervention, building all of the aspects up of that 5-pillar model. You will probably help someone avoid unnecessary admission to hospital, and most definitely an early admission to care homes if you build that resilience.
And I think one of the things we have heard about, will continue to hear about, and I think you've alluded to it already, is that dementia isn't necessarily a disease that is associated with the elderly or very elderly, because we've heard a lot about pre-onset dementia.
Yes. Mm-hmm.
And is that something that your charity is particularly engaged in?
Yes. So as I say, there's an image around dementia which is like quite significantly founded in a stereotypical image which is actually wrong. I mean, there are something like 4,000, perhaps 5,000 people living with dementia under the age of 65. there are forms of dementia that exist in children. There's childhood dementias. So if you think about dementia, less as that being the condition, and think about the brain diseases that lead up to dementia, you'll soon realise that the reason that it perhaps manifests itself in older ages because of the duration of time that the disease has had to progress through someone's brain. And it changes the perception. So, I mean, one of our key aims is to help people understand that actually, whilst indeed many older people experience dementia, that's actually been building up for numerous years, and support needs to be put in place much sooner to help do all the things I described in terms of that building resilience and help people live well with dementia. And we thankfully are doing some good work in that in Scotland. I think that we actually are a little bit ahead of the curve with this, which is something to be proud of, I think.
Thank you. Can we go to paragraph 13 of your statement, please? Because I think you transitioned from giving some of the background and the services that your organisation provides to talking about the campaigning aspect of your organisation. I'm going to ask you to read some of this, if I may, Mr. Simmons. But before I do, can I just ask you at this stage, and perhaps preparatory to some of the other information that I'm going to seek to obtain from you. Obviously, you say in paragraph 13 that as a campaigning organisation, you seek to influence policy and change. In the period before the pandemic, did you or were you involved at any stage in preparing for a pandemic? Not necessarily the pandemic we experienced, but preparing for a pandemic.
We only became involved in early March, February. We weren't part of a pandemic planning group of any nature prior to the pandemic.
Mm-hmm. Do you feel, and I will deal with this in a little more detail, but do you feel it would have been of advantage to Scotland society in general, and obviously those suffering dementia in particular, if you had been involved in that pre-pandemic planning?
I think if there had been any work done to prepare for a pandemic that did not include a very significant focus on people with dementia and thereby us as an organisation, that would be a huge mistake.
Yes. And just taking that probably a little bit further, and I think probably fairly obviously, that is because I think you and a lot of others that we've heard from within the inquiry and will continue to hear from, did envisage that one of the groups that would be most impacted by a pandemic, which involved in particular isolation, were those in care homes and the elderly, particularly those suffering from dementia.
Mm-hmm. Yeah, I mean, Mr. Gill, like our perspective is if you sort of break things down into really vulnerable groups, you have close to 30,000 people living within care homes. Probably 18 to 20,000 of them have got dementia diagnosis and some not. And then you've got 60,000 people potentially living in the community at home, and they're spread across the spectrum of the condition. So many people living at home will be in the advanced stage of dementia and maybe receiving a level of support that allows them to stay at home. Many others will be in that more middle, moderate stage, receiving support from organisations such as ourselves and many others. And then there'll be people who are in that very early stage who are just coming to terms with a diagnosis. And then you have the group who are just on the way to getting a diagnosis. So that's a huge population that rely mainly on human intervention. There are only 4 drugs to support people with dementia, and they don't support every type of dementia. So the essence of how we care for people with dementia is all about individual support and about really detailed understanding of how to best support that person and their family. If you don't have that, well, we'll probably, I'm sure, discuss it, but you will find very quickly the crisis that people find themselves in without that level of support.
Thank you.
I ask a question of Ms Simmons. You said a couple of answers ago that you weren't involved in any planning prior to March. You didn't give the date, but I'm assuming it's 2020.
Yes.
It's also apparent from the parts of your statement that Mr Gale has already been asking questions in relation to, that your organisation has a fair bit of connection with the Scottish Government. I see they fund you for certain things, and it's also fairly obvious that you have a degree of dialogue on, no doubt varies from time to time, with Scottish Government. Is that fair?
Yes, my lord. Yeah.
But do I infer, and I think it's a fair inference, but do I infer that the Scottish Government never approached you prior to March 2020 to ask for your views or any input you may have in relation to pandemic planning?
No, they did not, and we never approached them either. It wasn't something that was on our radar that we were trying to get access to. I mean, our focus in policy work was very much on developing the dementia strategies.
Oh, I understand that, but you'll understand I'm, no offence to you, but more concerned with what the Scottish Government may or may not have done.
Yes.
Mr Gill.
Thank you, my lord. Just going back to paragraph 13 of your statement, I wonder if I could just ask you to read from paragraph 13 through to the end of paragraph 15, because this, I think, encapsulates a lot of your campaigning and some of your ongoing work.
So, as well as raising awareness of dementia, we campaign for the rights of people with dementia. We're a campaign organisation seeking to influence policy and change, and we do that through developing strong, research, evidence-based policy reports, or by running significant campaigns. At the present time, the two best examples of that are our Fair Dementia Care campaign, which seeks to bring an end to what we regard as unfair charging policies in residential care for people living with advanced dementia. We are presenting to the government at the present time a strong legal case to what we think is the basis of that, and this has been a 2 or 3 year campaign. Our Long-Term Care Commission, which is chaired by Henry McLeish, former First Minister for Scotland, and Henry also chaired the Fair Dementia Care Commission for us. This is looking at what long-term care looks like, particularly as a consequence of the pandemic going forward. We also have a large piece of work ongoing about research and prevention, and we run a project that is mainly funded by the Scottish Government, which is about brain health and dementia prevention. This is called Brain Health Scotland, and is trying to help the public understand much earlier what they can do to protect their brain health. And this is an example of how the charity tries to innovate and develop new ways of thinking. Alzheimer Scotland funds research projects. Some of these include supporting a brain tissue bank at Edinburgh University, funding an Alzheimer Scotland Centre for Policy and Practice at the University of West of Scotland, and until recently, funding a centre in Edinburgh that has been ongoing for 10 years. We also run an important research recruitment programme in Scotland called Joint Dementia Research, which is a UK-wide initiative. And our aim is to prevent, care and cure, and our mission is to make sure no one faces dementia alone.
Okay, thank you. Now, the next section of your statement, you go on to consider the impact of the pandemic on frontline services. And this is obviously quite a significant section of your statement and a significant area of your concern. So again, I'd like you to read through that section, and at the end I'll ask you 1 or 2 questions about it. But if you read from, if you would, from paragraph 16 through to 33, please.
So prior to the pandemic, we were trying to prepare for the potential impact the pandemic would have arriving here in Scotland. We saw what was going on in Europe, and we were incrementally carrying out initiatives and engaging with government. I have to say that the engagement at the start of the pandemic with the government was particularly good. We were working very closely with senior government officials, the Deputy Chief Medical Office, and highlighting the concerns and issues. We were concerned that there is a huge population of vulnerable people who at that point in time were having to absorb very frightening information that the pandemic was coming. We were trying to keep things stable, keep people well informed, to make sure each time a new phase was coming, we were communicating that to people. We were also highlighting back to government about what the concerns were from the front line and how we could work together to alleviate some of that. An example of this was a leaflet that went out to everybody in Scotland about emergency contact details, including our helpline number. We were trying to balance the risks of what we were facing. We had 500-600 staff, and many of them were going to be engaging directly face-to-face with service users, through services or home visits. And a challenge for us was when track and trace stopped, as we were still running services for people. And to minimise risk to our day services, we set in place several protocols, including buying 600 thermometers. And we gave a thermometer to every member of staff and monitored each person's temperature before coming to work. When test and trace at that time stopped, there was a period when people had to isolate if they had a symptom, and there was not the availability for testing. And during that process, we were communicating with government the challenges to day services and indeed home visits. When lockdown occurred, we went from a fully functioning organisation providing all the face-to-face support to having some 600 staff working at home. The impact of that on us as an organisation was that a good number of people who previously had been receiving care from us were now at home and not able to go out and needing quite a lot of support. What we then tried to do was increase our helpline capacity, and we encouraged people to contact us if they needed things like food, medication or just connections. We also worked out a way all the staff that previously ran our day services went onto the phones and started making sure people were okay. And at that time, we got everyone settled down and worked out who were the most vulnerable people. We couldn't go into someone's house, but we could go and do an essential door visit to make sure someone was okay and to drop something off to them. And the team leaders that we had in place were all working through detailed assessments of individuals to understand who was most at risk. If there were people with high levels of vulnerability, we would be highlighting that. The most important thing was to maintain contact with people and to make sure that they were constantly engaged with us. And over time, our colleagues got very skilled and articulate at developing support through telephone contact. We then started running online support groups and activities. We started using Teams and Zoom. All of our football groups, artwork and therapeutic activities moved online, which I think was a remarkable achievement. We were painfully aware that behind all of that, there was a population of people that the digital and online activity would be difficult to reach. And our localities were doing well and seeking to continue the support for people. Our concern wasn't just for the people who we were supporting. There are 90,000 people living with dementia in Scotland. We were 100% certain that as soon as the measures of lockdown started, the pressure on that community, especially on carers, would be inordinate. And we were extremely concerned about what their experiences would be like. That group of people who recently had a diagnosis but who weren't able to access post-diagnostic support, there were also people waiting for a diagnosis, and that is a horrific place to be. They couldn't get it. All other services around about that dementia diagnosis were closed. There are lots of people with dementia with complex needs. It was also a challenge to navigate non-face-to-face contact with GPs, and we were concerned that there would be a physical impact on some people because they couldn't access the general healthcare services in the same way. There were complex hurdles to access these services. In addition, there were people living at home and people living in care homes, and our responsibility as a representative organisation was to try and highlight the issues that these individuals were experiencing directly into government and use that information to reshape services. The impact on our staff was huge. So to begin with, we had to get staff in a place where they made the transition to working at home, and we helped them do that. We then started to embrace technology. An example of this, I did a weekly update video call for all staff, and we tried extremely hard to keep staff on board, and I think they found the initial days traumatic, as our staff are all about relationships with people. They did their best to maintain relationships. My main concern at that time was for the people living with dementia in the community. There were three big areas that we felt would be problematic for them. People would run out of money quickly, food or medication. And a lot of people we supported would have their regular routines of popping out to the post office to pick up their pension, get some shopping, then go to the pharmacy. All that stopped. we were trying to make sure no one was left completely on their own with that. During this time, we had a strong connection with the Scottish Government's dementia policy team, and I was talking almost daily with senior civil servants trying to influence policy, but at the same time get advice back. I felt at that time we did some positive work to help the communication and let the government understand the experiences people were going through. And we were receiving information back relating to how COVID spreads, etc.
I'll just stop you there, Mr. Simmons. Just going back over some of the things you've said in that section. Right back at the beginning, in paragraph 16, you say that at the start of the pandemic, the engagement with government was particularly good, and you say that you were working very closely with senior government officials, the Deputy Chief Medical Officer, and highlighting the concerns and issues. Can you give us a little more detail of that, please?
Yeah, sure. So what we engaged around were primarily the issue of how, first of all, we communicate. So we designed leaflets explaining, the virus and how to use the sort of measures in place at that time. So we designed joint leaflets and shared that communication. We were also getting advice about how the virus spread, and there was quite a bit of dubiety at that point in time. So there was issues about could it be spread just through people having symptoms, or if someone was asymptomatic, would it spread? And Mr. Gale, like I described to you, that at this point we've got hundreds of people, indeed thousands of people, receiving support within our services. And we are trying to make sure that we don't become a risk factor within that. And we're trying to make sure that all of our staff and the people that are coming are following, good hand in respiratory hygiene.
Just stop you there. So you wish to avoid being a risk factor. How would you have been a risk factor?
I think if our staff hadn't been really, really diligent in all the mitigating measures, and if we hadn't been so focused around making sure that if people had any symptom at all, which is where the thermometer was important, because in the first couple of weeks, we maybe had one or two people around one of our services that might have been going through the test and protect system, which meant that they had been connected to someone who had been tested. And so we were able to monitor that very carefully. That stopped. So we were then faced with what is the best way of ensuring that any of our staff coming to work actually are as safe as possible. So the idea that we came up with was, well, one of the key symptoms is a temperature and a cough. So that led to us having a very consistent process of every single member of staff before they came to work went through a protocol of taking their own temperature, making sure they had no symptoms, making sure they hadn't been around anyone with symptoms, and then coming to work safely. So I think that was essential to keep it going, and that's where we were engaged. We were talking, to senior officials. We were getting advice back about, the symptoms. We were part of a group that was trying to keep things going for probably quite an intense 2 or 3 week period.
And in that very early period, your dialogue with government officials, understand that you were receiving from officials information about transmission of the virus, etc. What were you giving back to officials at that time? What information at that very early stage were you conveying back to officials?
So the types of things, we were probably at that point just highlighting the scale of services and the number of people that we would be thinking about. I mean, sadly, we don't have very good data on dementia in Scotland, and we would be, at that point in time, getting an assessment of how many people had phoned our helpline up, what were the issues coming through the helpline, what types of things do we have to think about, and we would feed that directly in. We would also be feeding in our experiences of what's the interpretation of our community in terms of the measures that we've been asked to take, and is that working? What do we need to do about that? And we would feed that in.
Now, I don't want you to disclose the names of any particular officials that you were dealing with, but was there a particular department or that you were liaising with this information?
Yeah, I was working extremely closely with the dementia policy team at that point in time, a named individual, and the type of sort of relationship that we had was actually quite long-standing. We'd worked together on a number of strategies, so that was fine. But we would be able to call each other within a half hour if we needed to speak. There wasn't any delay. Mm-hmm. If there was issues that we had to discuss or engage with, both parties would react to that. We were taking it incredibly seriously, trying to get as much safety into our system as possible.
At that very early stage, and I think we are all mindful of the fact that in many respects we were dealing with the unknown.
Yeah.
What was of particular concern to you at that very early stage?
I think we obviously were looking at across to Europe. We were seeing the types of things that were happening. We were getting information about the fact that actually this virus could be airborne, and there was, you know, in the early days, I think a fear level that was permeating through our community in such a way that you know, it was terrifying for people. And my biggest concern was to try and make sure that those individuals that we were connected with and supported felt confident in the advice that we were giving them, and that the advice we were giving them was accurate and as detailed and as well balanced as possible, and trying to reassure people that we would be there for them and we would help get people through this.
An aspect of that is obviously communication, and yes, we'll come to this in further detail as you go through your statement. What are the particular difficulties of communicating with the dementia community, if I can put it that way?
Yeah, I think that we obviously have a very sort of dedicated communications team, and there are various ways that we would reach out to people. So at that point in time, there are a number of people that you know through their families and connections that you could probably reach through a social media communication, for example. But for many more people, it's a matter of writing and a matter of engaging and directly communicating. We also have a large group of people who receive monthly update from myself as just members and supporters, so we can get general communications out. But what we were never able to do, and we simply wouldn't have had the resources for that, would be identify who the 90,000 people living with dementia are in Scotland and send a communication out directly to everyone. We had to rely on public sort of messaging coming from government across the sort of like the broader areas of communications to reach that community.
And I take it also I can put it this way, the tone and content of what you would be communicating would be important, given the recipients of the information.
Yes, and that's where I think the partnership working was pretty much important, because we were agreeing what the main message would be, and then putting that into as, well, for want of a better term, as dementia-friendly language as possible. I mean, trying to make it something that people could understand, and I think that worked pretty well. So good.
Thank you. I'm just taking a number of points from that passage, that number of paragraphs that you've read, Mr. Simmons. Can we go to paragraph 30, where you talk about people living at home, people living in care homes, and you say our responsibility as a representative organisation was to try and highlight the issues that these individuals were experiencing directly into government and use that information to reshape our services. Now, I think you've explained what you were trying to convey to officials. Can you just explain how you were utilising the information that you were receiving to, as you put it, reshape our services?
So if you imagine that we start to receive a really significant increase in number of helpline calls and issues and concerns about, shall I say, for example, like, you know, people worried about getting money, worried about getting medication, food. So we would then feed that in and follow that up with perhaps some proposals about what could be done about it. And indeed, from my perspective, what we did, and this is a little bit further on, Mr. Gill, in the very early stages, but what we did was we realised that we had to bolster that frontline support. So as well as having the helpline, we then brought in, you know, some of our dementia advisors and skilled practitioners to help people at that point in time. We also then sought to use our localities to provide that front line. But what was also happening was that other organisations, there were other really good community initiatives starting to take place. So you would want to try and make sure that that was all strategically coming together and that there was a connection between that. And at one point, the general idea was that there may be one national helpline that would then feed people out into sort of, like, you know, more specific areas. So if someone contacted the national line, they would then, if it was someone with dementia, would then come to us and we would support that person or support that locality. So this work was, I mean, I don't think it ever really got like a fully embedded sort of strategic sort of, you know, strong position going forward. But in the early days, that was the type of work that was being discussed and the types of things that were being looked at and considered.
Okay. You mentioned that the impact on your staff was huge. And I think we can readily understand that, not only at the beginning of the pandemic, but as the pandemic progressed. Did you lose many staff? I mean, did many staff just leave the organisation during the pandemic?
That was never a big feature. I couldn't give you an absolute figure just now, but no, I have to say that and if you imagine our staff are ranging from a support worker who work within day services, to a dementia advisor, operating across a community, to a link worker, their level of commitment was remarkable. And I think, I mean, it's further on in the statement, Mr. Gale, but our staff were want to be out in the front line. They were want to visit people. They were want to open up services. Mm-hmm. They weren't stepping back from it. Mm-hmm. They were desperately keen to step towards it. And as a chief executive, that was probably one of the most challenging things for me, was to see all of these staff who were dedicated and committed to helping people, but having to hold them back.
And I imagine something about which you would be very proud.
Without a shadow of a doubt, I think that the way that our staff, when we got back out, were very brave, and what they did to innovate and develop and to go the extra mile for people, I probably don't even know the extent of that, but the sort of ethos amongst them was just remarkable.
Mm-hmm. Okay. Right. Can we go on to the impact on individuals and families at paragraph 34? And again, can I hand back to you to read some of this, please? So if you read from paragraph 34 to the end of paragraph 40, 40, please.
The people we supported were extremely impacted by all the measures, and I think disproportionately by the measures overall. If you were to start at the far end of the dementia spectrum, the people with advanced dementia who require 24-hour care, who live in a care home environment, maybe not having the capacity to consent or the ability to agree to some of the measures that were being implemented. What we were concerned about was the day-to-day experience of people being isolated in their room. Then there were people with more advanced dementia who were looking after in terms of day services or were being looked after at home by their families. This was a significant level of need, and all of those individuals were now getting passed on to families. There was little in the way of other support to get into that person's home, no respite, and a lot of our work previously had been giving family carers the opportunity to have a day or an afternoon respite. Due to the pressure in the families, we got a sharp increase of helpline calls and people looking for increased levels of support on the telephone. We then increased our helpline capacity to give people more support and so we could take more calls. And we found there were lots of stress and distress.
Can I just pause there? Stress and distress, on whom?
The majority of calls that we were receiving were directly from carers, and at this point in time, Mr. Gill, what happened was that everything stopped around about that carer and that family, unless there was a real sort of significant, substantial need and a big level of support going in. And the family were then faced with, and this is at the point of lockdown, being entirely on their own, 24/7, with very little access to support. And if you can imagine that someone who is trying to understand that, who's living with a complex form of dementia, and a carer on their own trying to help that person understand that, but not just that, trying to get through their day, not knowing if they're going to be able to get their shopping or have a meal for the next day, not knowing if they can get to their GP, not knowing if they can get access to any form of support. This was the types of calls that we were receiving and the type of stress and distress that our community was under.
Understand, thank you. Yes, we carry on at 37, please.
Then as a group who were recently diagnosed, we would have normally been working with many of these people to help them build resilience to continue to live well with dementia so they could keep going to everyday community activities. That all stopped. At the point of diagnosis, we tried to use every single part of the person's community and their own personal strengths to build a platform that gives them resilience to live well with dementia. That platform was not only there with only their family for support. Finally, you had a group of people who were waiting on a diagnosis, and there are potentially 15,000 to 20,000 people each year developing dementia in Scotland, and all of them sitting not getting a diagnosis. What we saw very quickly was that the impact of lockdown and the measures were falling on carers, family members, and the stress they were under was huge. People were desperate. In addition to these issues, some of these people developed COVID symptoms or COVID and were admitted to hospital. Carers were not allowed to go with them. Our staff were dealing with carers who were phoning up saying, "My husband's been taken to hospital in an ambulance, but I can't go with him." There were many people who never saw their loved ones again. We quickly saw trauma and pain and levels of despair that I've never witnessed in my whole working life before, and we tried our best to help them, but very quickly it became a crisis. In the initial stages, we were preparing for the pandemic, and this included producing information leaflets, communications, and risk management approaches to try and keep services going. We were in a situation where we tried to remodel their services to give people support. At that point, we saw very quickly through our frontline services a level of crisis and stress.
Now, can I ask you a few questions, particularly about paragraphs 39 and 40? Obviously, one is progressing into the pandemic, as you're reflecting here. And I'm not particularly concerned about precise dates, Mr. Simmons, but I think we can infer various things from what you say. And if you can give some indication of timeframes, that would be helpful, but I'm not looking for precise dates. You say that at the beginning of paragraph 39, what we saw very quickly was that the impact of lockdown and the measures were falling on carers. Yes. First of all, can you give some context to what was very quickly?
So, I mean, for us, even the message about lockdown caused significant stress to people. And the calls to our helpline, probably as soon as lockdown was announced, was, what am I going to do? How can I get help? What's going to happen? Soon after that, the issue about whether or not people could go and visit someone in terms of their family members coming to that person's house, in terms of social care provision, you know, what we very quickly seen was that most things stopped. and people were, as we know, locked down. And that's when I think the normal levels of community support, the normal levels of family support, and normal levels of state facility support just were gone. And people were trying their best to get through that. So we did have, couldn't give you a precise number, but within a 2 or 3 week period, you know, we certainly had people who were really struggling to get access to their medication, who were really struggling to I mean, online shopping wasn't a great big thing at that period of time. You know, there was, I mean, these were the primary initial concerns we had was like, goodness, people won't have cash, they can't go out to go to the bank, they maybe went to the post offices, they're all shut, they won't be able to go and get shopping because you couldn't get into the supermarkets. It was really practical, you know, like essentials that we were deeply concerned about getting to people.
Yeah. And you give the example, which I think is probably obviously anecdotal, of a carer phoning up and indicating that her husband had been taken to hospital. Yeah. Query whether that person was ever going to see her husband again. Mm-hmm. Was that something that happened on a number of occasions?
Yes. I'm afraid I don't have any sort of like hard quantitative data on that.
I'm not looking for that.
But Mr. Gill, I mean, very often I would have staff members needing to be supported by our senior leaders to deal with that because they were receiving calls of that nature quite frequently, and just I mean, family members just in absolute, you know, bewilderment as to how on earth can my loved one go to a hospital and for me not to be able to go with them or see them. And then we also had people trying to get contact numbers in the hospital, trying to find out where their loved one was. And you know, I mean, I completely understand the difficulties the hospitals were experiencing at that point in time, but there was just that basic, you know, information about how a person was doing and how they were faring and what the sort of treatment plan was just stopped. And in a sense, not in every circumstance, obviously, but for some people, that was the last time they saw their loved one, and they then had to deal with the grief and the trauma of that. But we were picking up, and not just us, I'm sure other organisations very much were in the same position. We were picking up people in that position and trying their best to help them deal with that. But very, very traumatic for that individual and for the staff that were dealing with that.
You mentioned twice in 39 and 40, you say very quickly it became a crisis, and then you refer to a level of crisis and stress. Can you indicate what you mean by crisis and for whom it was a crisis?
Yeah. So my meaning of crisis in that circumstance is that it's not just for one individual, it's not a one-off event, it's pretty broad, it's happening pretty regularly, and it needs urgent attention. And I think that there's no doubt it's a crisis for the individuals involved, but for us, we were looking at this and thinking, we've moved from a reasonable system, not a perfect system of like dementia care at all in Scotland, not perfect at all, but we've moved from a reasonable system, reasonably well positioned in terms of diagnosis and post-diagnostic support and day services and advanced care, to having none of that. And we're expecting somehow through, you know, their own resilience and determination, families to pick up on all of that on their own. That's where the crisis came from, and that's, in my opinion, an unreasonable expectation to think that you can take away a whole care system and hand that over to families to deal with.
I suppose, putting it objectively, would it be fair to say that the services which you had, as you explained, over a relatively long period of time developed and were developing could no longer be delivered by you?
My Lord, that's exactly correct. Everything had to stop. And the difficult part, my Lord, about that is that it's all that human intervention which is the service. So it's all based on your ability to interact and support individuals and give them that strength of connectivity and connection. And that's the thing that probably we were very proud of about in Scotland, and not just Alzheimer Scotland, but a lot of dementia practitioners, having transformed our system over the past sort of 15, 20 years towards that, and I think had a reasonable system, it did stop.
Mr. Gill.
Thank you, my Lord. And I suppose just taking that slightly forward, Mr. Simmons, you had a difficulty, or your staff had a difficulty, of providing the level of service that you had been doing. And of course, those who were in a position in the community to care for people with dementia were similarly having a difficulty in providing the sort of level of care that they could provide.
Yeah.
So it was, I would just make it sound facetious, but it was a double whammy.
Yes.
Yeah.
Yes, without a shadow of a doubt. And I think that at that point in time, as I refer later on, Mr. Gill, in my statements, we weren't pandemic experts. We didn't understand how to handle a pandemic. We were trying to help people understand why these measures were there. We were taking the advice and the lead from the government and scientists on that. But at the same time, you know, every aspect of what you would regard as a community infrastructure was just having to stop. And that's where I think that a human service of the nature of dementia care, you can't do that. You just can't stop everything, no. You know, and that's where the biggest problem starts to arise.
Yeah. Okay. Right, could we go to paragraph 41 and following, because there you say what we did about this. And again, can I ask you to read through to the end of paragraph 45, please?
So in May 2020, we wrote a proposal to the government requesting that we open our resource centres to provide people with short respite breaks. This was 2 months into the pandemic. We were so deeply concerned that people needed respite, social connection and opportunity. And we designed a system to use all our resource centres with proper social distancing, with very small numbers for a couple of hours. We felt that people were missing out on this. We started highlighting these issues directly into the dementia policy team at the Scottish Government, and I wrote a couple of proposals at that time. The biggest areas of concern in the early days was the need to give people help and support. What seemed to happen was that the Scottish Government created the structures through which they were going to make bigger generic decisions. An example of this was the CPAG group that was set up, and other groups were established. CPAG's Clinical Professional Advisory Group. Our proposals, which in the past would have been decided upon by a dementia policy team, had to go through the bigger groups and boards. And we never got permission to open up our resource centres in May 2020. It was at that point I felt that dementia started to get lost and our client group started to fall down the priority order. We didn't get our centres open up until a year later, even though we had a comprehensive risk assessment and plans. We were constantly writing, campaigning and highlighting that need. We published the first version of our COVID-19 The Hidden Impact report in November 2020, and we updated this in July 2021. The report highlighted all the concerns that we had. The impact of the measures on people's physical, psychological and emotional health were huge. But add into that people living with dementia and their family going through this, it's phenomenal. We pushed hard for our resources to get opened back up. The impact of these centres not being open was detrimental to their health and well-being.
Can I just stop you there? A few things from that section of your statement. Mr. Simmons. Going right back to paragraph 41, you say in May 2020, so 2.5 months into the pandemic, you wrote a proposal to government requesting that you open up resource centres. Why did you do that?
Sorry?
Why did you do that?
Mainly because of what I've described, Mr. Gill, was that the crisis that people were going through and what they were experiencing. And also, whilst we were, and I should say, I think that we were supporting a lot of people in a very positive way through our online and digital activities and connections. We delivered about 6,000 online groups, and we're helping many people in that way. And many people, that was quite a strong level of support. We just knew so many other people who couldn't utilise the online supports needed that time, needed some support, needed some respite. We also wanted to use our skills because, I mean, within our services, we know there's things that we do help alleviate the symptoms of dementia. We know that by providing sort of cognitive stimulation, engagement and proper activities and reminiscence work, we help people maintain their sense of self. We help people just live better with dementia, and we weren't reaching everyone. So our concern was that. And actually, I think that I was very, very fortunate insofar as I had a really great safety and well-being team who got on top of all the sort of measures and guidance, and we wrote really detailed, very intricate proposals about how we could do this safely and in a way that would meet all the guidance that was available at that time.
And obviously, that's the point I was actually going to ask you about. How to do this safely? This was a part of what you were proposing to government.
Yes, Mr. We actually, and submitted as part of our Rule 8 evidence that we wrote very detailed, from the point of someone leaving the house to coming to the centre and what would happen in terms of cleaning everything and all the sort of forms of cross-infection measures. I think my team did a fantastic job with that, and it could have been done in all regards, as safely as anything else was being done. There are no guarantees that it was non-risk free. It was obviously going to have some risk attached to it, but the balance that we were arguing was the risk of not doing it was starting to be outweighed through the risk of doing it. And we were quite confident that if the measures that were in place to minimise risk were competent, then we could have competently delivered that.
We'll come to the balance that you've alluded to there in due course, Mr. Simmons. But so far as you were concerned, in May 2020, this balance was coming into play.
Yes.
You say in paragraph 44 that the government structures that were in place, particularly through CPAG group, were ones, as you put it, to make bigger generic decisions. And do I take it as a consequence of that, the more, I won't say micro, but the more detailed proposals that you were making in relation to dementia, well, you put it, were lost?
Yes, Mr. Gill, what we found started to happen was that very strong connection and engagement with the dementia policy team continued. The dementia policy team, and we're on the outside of this, Mr. Gill, so I can't say for a fact what happened there, but the impression that I had was that the dementia policy team, rather than being able to make a decision, had to refer that up the way, and that decision or that request then had to be put in balance with numerous other decisions that were being made. And what seemed to us to happen was that this is where the formation of blanket decisions started to come into play. So it would be things like no daycare can open up at present time, no visiting in hospitals, no visit. Very big sort of generic approaches to decision making. Now, we followed on our arguments, not right at this point in time, but later in the day, we were arguing to say that dementia policy team actually should have been a directorate, and it should have had its own dedicated directorate, and that directorate should have had the power to look after the issues of people with dementia throughout this pandemic, and we got to that later on in the day and wrote proposals to say this is what really needs to happen, because the size and scale of dementia and the number of people living with dementia, and indeed the issues that were evolving within care homes, it was merited to have a dedicated dementia lens and focus, and to make decisions specifically around that. And in a sense, Mr. Gale, that you know, these were big decisions that could have been taken. They weren't small minutiae. You know, arguing to restore a form of, you know, human intervention and care for people with dementia across Scotland is a big decision, and it really should have had its own focus. And I think that what happened was that, you know, we were trying to do what we have always done, which was produce evidence and be responsible and, you know, diligent in our efforts to get that in front of key officials and ministers where required. But we struggled, and we got, and I have to sort of say that, you know, we were getting support from the dementia policy team to try and push these things on. We got good support from areas that we wanted to convert our day services to home-based support, and we got help to get the care inspection, registration started. So there was stuff that was still happening that was good. But what really, in my view, stopped happening was this engagement of, let's look at dementia, let's look at 90,000 people, let's think of the, from the point of pre-diagnosis to diagnosis to, you know, like late-stage care, what are we going to do about that? And I feel we should have had a specific strategy around that. We got a recovery plan a little bit later on, but that missed a lot of what could have been done earlier.
Two things that I can perhaps ask you about just for your comment. Anxious not to put words in your mouth, but I will. Did you get the impression that once your representations went from the specific dementia policy team beyond that, that there was a lack of priority being attributed to it?
It's very difficult. As I say, we weren't inside to see what the reaction was. But what I suspect would happen would be that we might be making a case for people with dementia, and then, from my own experience, I'm pretty certain the learning disability community would be making a case from their perspective, and I'm sure others would be making a case. So the various policy teams would be sort of like trying to deal with these issues and represent that into a body such as CPAG to make decisions. Now, I mean, obviously, from my perspective, I'm going to argue the case and say, for people with dementia, like, we would have expected to see someone look at our proposals and say, so here's an organisation here that's willing to get their staff back out into the front line, that's prepared to sort of try and mitigate these risks and want to work with us to do that. Let's at least try and give it a go, yeah? And then build on the priorities behind that, particularly when we produced our hidden impact report in November. By that point, we had one day service that we managed to open just for a short period of time in Dundee, and then had to close again because we went into a further period of lockdown. But we feel that we produced a very well-informed, comprehensive report that highlighted all of that we've been discussing today, Mr. Gale, and he put that in front of government. We felt that would have and should have been, you know, treated with a significant degree of reaction.
Yeah. And the other point that I'd just like to ask you directly, Mr. Simmons, you didn't get permission to open your resource centres in May 2020. What was your reaction to that?
So I think that, again, like, we had to have some sense of understanding that we weren't pandemic experts. So I mean, we sort of muted it on the 20th, and then we wrote a proposal on the 29th, and then what we did was that we kept giving people the support we were given. We then decided to produce a really well-researched report that I mentioned, the impact report. So we went from just writing proposals and making recommendations through proposals to writing really detailed reports with an evidence base behind it. Alongside that, that became our argument. So we just kept going, and you know, it's not the first time that we would be dealing with government issues, trying to make our case and having to consistently make it for prolonged periods of time. Yeah. And what we did keep doing, though, was we kept our community informed that we were trying, and we kept people aware of the fact that we were trying. And there were parts that we could understand that it might be difficult amidst everything that was going on for people to be so focused around about our one proposal. But the truth is that the proposal was just a reaction to the stress and crisis, and it was just a starting point of what we wanted to see change.
Yeah.
Mr. Gale, it's past 11:15 now, so
yeah.
I think we should take a break. But before we do, I'd like to ask Mr. Simmons one question arising out of what you've just been discussing. It starts with the penultimate paragraph, the penultimate sentence in paragraph 44. We never got permission to open our resources centre. And you've explained how you submitted a plan to them. It was a detailed plan. It had been thought through. There was a fair amount of work. And I think I infer from what you've said that you went on when that wasn't accepted, and you prepared a further plan, an impact study, which was submitted in November. And I understand that, and that's very clear. You also have, in fairness, said that you accept you weren't pandemic experts, and that no doubt the Scottish Government had other interested parties that they had to consider as well. But was there any time in May or after May, and between May and November, that the Scottish Government entered into dialogue with you about these plans that you had submitted?
Yeah, my Lord, we were regularly discussing this with our contacts in the dementia policy team, and I think that it would only be fair of me to say that I suspect they were regularly discussing it with their other bodies and groups, and I think that as I mentioned, not being in the room, but I think it would have been a very busy room with many agendas and issues being brought to bear. And what we wanted to do was give the dementia policy team enough evidence and strength of argument to take that into these environments and try and ensure that they could make the case for us, which is what really was the only way we were going to get the decisions made, my Lord.
Yeah, I understand, but you're making an inference that the dementia policy team were taking the issues you were raising to some other body, let's assume, at a higher strategic level. Yeah. Was that ever explained to you? Yes,
yeah, and I had access to emails and exchanges and saw what was going on, my Lord, and it wasn't that nothing was happening, and I suppose from my perspective it was a matter of just keeping pressing on all different quarters and different areas and trying, and I have to be very honest and say that there was some risk and trepidation about, are we doing the right thing here by trying to get to this point. I mean, at that point in time, I couldn't have said I was 100% confident that there was no risk to this at all, but I knew what I think people needed and what had to happen, and was prepared to take that risk. So we were trying to work through the system as it was to get the best outcome. And to be fair, the fact that we got one opened in November before we went back into lockdown, I felt was quite an achievement, quite a success, because no one else had at that time. And we were probably, I think, in some ways sort of getting used as a potential sort of pilot case to see if it were possible. So I think that, all things considered, getting to the point where we got one opened and we started to see that it would work gave us great confidence. And at that point, we started to get stronger and stronger about what we felt could happen through the reports and the engagements. Okay, that's clear. That's helpful. Thank you. Shall we come back about 25 to?
Thank you, my Lord, yes.
Take a break now, Mr. Simmons. Thank you. Good. Right, thank you again, Mr. Simmons. And Mr. Gale, when you're ready.
Thank you, Lord. Mr. Simmons, could we go back to your statement at paragraph 46? And I think you begin with a caveat there that you are aware and were aware that you were not pandemic experts and had to be guided by public health. And you then carry on to make a fairly significant statement. Could you just read paragraph 46, please? And then we'll look at the individual points that you've set out.
I was aware that we were not pandemic experts and had to be guided by public health. Once we realised how the infection travelled, we could understand some of the reasons why it could be difficult for us to do what we wanted to do. But we got stronger in saying the impact on people was so significant that we were seeing people in the early stages of dementia jump to a mid-stage, more advanced stage rapidly. And all of this is contained within the COVID impact report, and we highlighted.
I'll just stop you before you go into the particular points. This team seems to reflect an increasing confidence in the view that against the, if I can put it this way, the matter of infection control, there was a balancing concern that you had in relation to the impact on the dementia cohort within Scotland. Is that right?
Yes, Mr. Gill.
Yeah. And you go on to highlight the following key points. And I've read this several times, and I think overall it is a very, if I may say, a very comprehensive and a very insightful set of points. And I wonder if you'd just read through them, please.
So we highlighted the following key points: the impact of social isolation and loneliness, impact on well-being and mental health of the loss of usual support networks, both formal and informal, and resulting loss of meaningful social interaction, negative impact on relationships, frustration of people with dementia not understanding the reasons for restrictions, leading to friction within family and carers, impact of increased burden of care on family carers and resulting carer stress, the trauma of increased stress and distress among people with dementia and family carers who are trying to cope with it alone. Carers reported a decrease in their physical and mental health from the additional burden of caring as a consequence of the lack of previous formal and informal supports. The impact of not being able to spend time with family members in care homes caused substantial levels of anxiety and emotional trauma for both families and people with dementia. People with dementia and their families reported that the symptoms of dementia increased and that those cognitive skills declined as a consequence of the isolation they experienced. The emotional stress and loss felt by carers with dementia being admitted to care homes because of accelerated symptoms of dementia and carers struggling to cope. The trauma and increased stress and distress among people with dementia and family carers who are trying to cope alone. Emotional trauma of care home admissions, which are often abrupt, unexpected, and often pressured because of lack of alternative support. The emotional trauma of bereavement during the pandemic, not being there at the death of a loved one, restrictions in funeral services, lack of ritual and family support and grieving together, carers delaying treatment for health conditions and ignoring their own health due to the increased caring responsibilities and lack of respite or breaks from caring, carer exhaustion, overwhelming stress and feeling inadequate.
Yeah. Just 2 points I'd like to pick up from, well actually 3 points if I may. The third bullet point that you make, the negative impact on relationships. What relationships do you have in mind?
So the way that we conducted this research, Mr. Gill, was that we got all of our link workers to talk to people and go through an assessment of what was happening. So people were finding it difficult to be in the lockdown environment, perhaps on their own and just sort of, having to deal with some of the the challenges and difficulties of that intensity of the living with dementia and not having anyone else to help you with it and being there all the time. So we were getting some reports that there were frictions and difficulties there amongst relationships that people were experiencing that they needed a bit of support with and a bit of time out from that they couldn't get.
And obviously respite was not really an option.
None, no.
Also, you mention that people with dementia and their families reported that symptoms of dementia increased. And is it possible to measure that? Can one actually see that happening?
I certainly think that if you were living with someone who had a recent diagnosis of dementia, and you would be looking at perhaps key things, that what were the main issues. So someone might, for example, be forgetting routines, forgetting sort of, like names, forgetting places, stuff of that nature, or indeed just having some difficulty with basic function. There's a big difference between that early form of symptoms to someone reaching a point where they don't recognise themselves in a mirror, where they perhaps have no real understanding of just where they are and what is happening and the progressive nature of that. You would see that very quickly, and I think that perhaps that's two different sort of extreme positions I've described there. But what we concluded was, on balance of everything that we were hearing, that it looked like people who were in the earlier stages were moving very rapidly to the mid stages.
And was it possible to, from the work that you had done and the research that you had gathered, was it possible to at least make an assessment of a causal link between anything that was going on and that increase in the rapidity of the disease? Yeah,
we couldn't have. That would have required a really proper, detailed research approach. But we were confident enough to take what we were hearing from our link workers and what we were getting directly reported from people, carers and people with dementia themselves, to make an informed statement that it was quite clear to us that because of the lack of any other forms of intervention to support someone's living well with dementia and reduce their symptoms were getting far worse. And then on top of that, I think the interrelationship between physical health and frailty and dementia is also quite important and quite complex. So what we were seeing were people who just not even being able to go out and get a walk because perhaps that could have led to some difficulties because of the social distancing or understanding of that nature. Physical health was significantly declined, and we reported on that. And we also were seeing some changes in medication prescriptions. So people were getting, we heard more frequently people were getting prescribed anxiolytics and sort of more sedative medication to help alleviate some of the pressures and tensions. Now, what that then does is it makes people sort of far more sedate and they sit longer, and that causes more sort of like physical problems. So I think that we couldn't say for definite, but I think we could make a very well-informed statement around it.
Well, I think it's important that you mention physical impacts, because one of the things that I think we picked up, certainly in reading some of these statements, is, and perhaps one that wouldn't necessarily be immediately apparent, a lot of people seem to have reported, either in their loved ones or individuals reporting themselves, difficulties and adverse effects on posture.
Yes.
Is that something that you came across?
I think we probably described it more generically around about frailty, and one of the things obviously we're doing very often within our services, and everyone's encouraging people, is to keep active, to keep engaged, to keep walking, to keep your heart functioning and your musculoskeletal system getting utilised. that's very difficult when you're in that sort of lockdown period. And the frailty issues, I mean, I'm not a frailty expert, but again, I think that what you'll hear from experts is that it's quite rapid. You don't have to not be doing something for very long to lose sort of muscle mass and you lose posture, and you really need all of that rehabilitation and physiotherapy support to rebuild that and engage it. So it doesn't take long for there to be quite significant decline physically in people who are not mobile and being supported with that.
Mm-hmm. And just the final point, if I may, and it's perhaps may seem a slightly insignificant point, but I'm not sure it is. The final bullet point, you mentioned that so far as carers were concerned, there was a feeling of inadequacy. Can you just give that some context to that, please?
Again, Mr. Gill, that would be coming through our sort of, I mean, our link workers are dealing with people in that earlier mid-stage, and they're getting constantly, talking to people and getting a sense back from, what more can I do? I'm not doing enough. I feel my loved ones declining. I can't get access to help from them. So you would have, that group of people. Then you would have people who were a little bit more progressed, who were talking to our dementia advisors and phoning our helpline, and just feeling that probably when they had a need to get access to some form of help or support, that they couldn't do it, they couldn't deliver it themselves, and that sense of, just feeling inadequate, rather unfairly, I think was very common. I think people felt, I should be able to fix this, and you would have sort of broader family members coming in hoping that they can fix matters to support their mother or father, and they just couldn't. So that the level of overwhelming sort of stress, and then exhaustion, and then just feeling inadequate, it was very common in people.
Okay, could you go back to paragraph 47, and from there on to eventually to paragraph 59, you talk about further things that you did and interactions that you had with government. Yeah. Would you read on from 47, please?
As an organisation, we make sure we work with evidence. We put all of that into the hidden impact report and made several recommendations. Things like the balance of risk between the measures and the social engagement requirements of people living with dementia, use of antipsychotic medication. There's evidence presented in the report of other people's work that demonstrate the increase in antipsychotic medication, and we were campaigning about the impact of the excess death reports. In that first year, we moved quickly into saying as clearly as we could how this was having a massive effect in our community. We demonstrated aspects like how difficult it would be for someone living with a significant level of dementia to try and deal with understanding social distancing and all the measures. We wrote letters and reports to relevant ministers. We had meetings with ministers such as Claire Hawkey and Ms Freeman. All of this is listed in our documents that we submitted. From mid-March to 2020 onwards, we had regular contact with senior Scottish Government officials from the Dementia Policy Team, mainly via email contact and a regular one-to-one call. We were also part of a weekly stakeholder engagement meeting, and throughout this time, we were explaining our concerns and offering proposed solutions. We've been advised that we cannot share the email exchanges, but to give you a sense of how we did, here are a couple of early emails that will allow you to see how these concerns were built into a proposal to open our day services back up for the specific purposes of alleviating the pressure on so many carers and avoiding the ongoing trauma. So on the 20th of the 4th, 20, I put this to officials. It might be helpful to share some of our further thinking on this. As you know, we are starting to see a high volume of calls from our helpline with people struggling to cope with the pressures of lockdown. We think that when people start returning to work, the current family-based supports will be lessened and the potential of some people in significant difficulties will increase. We don't think people remaining at home and receiving one-to-one support is enough for some people or for their carers. We are considering if we could use our current day services to provide some form of one-to-one support and much-needed respite for those in greatest need. The scenario might be, for example, a previous 8-place daycare service with 3 staff could provide 3 places each day, providing almost one-to-one daycare support with lots of room to do so safely, adhering to social distancing and stringent cross-infection measures. We think this could be done, but we need full support in terms of testing and PPE. We can obviously expand on this, but to me it's definitely possible. One that would allow us to do some meaningful work with individuals and provide some much needed meaningful respite for carers. We probably will also want to think through small-scale forms of therapeutic group work, peer support and community connections for those less advanced in the earlier and mid-stages too. We can't expect people to remain completely isolated for several months to a year, and I think we could argue that these are essential clinical needs as much as social. We could be talking to this group of people, asking their views on this, and coming up with some safe, small opportunities for people and their families that will complement the online support and connections. Again, similar to the above scenario, this might need to be done with those in greatest need. We continue to highlight these issues, and on the 29th of the 4th, 20, I wrote, "Thank you for agreeing to consider this proposal. We are desperately keen to develop this and safely offer some form of therapeutic activity for people with dementia and provide some critically important respite for their carers. I have been talking directly with all of our staff, link workers, dementia advisors, locality teams and volunteers, and listening to the issues that they are dealing with, and I am quite clear that it is not an exaggeration to say we are sitting on top of a pressure bubble that is ready to burst. Reports from our teams tell me that their support calls are getting longer, families are deeply concerned that they can't keep this going, and the level of pressure and need for a break is as high as it can be. This is the main driver behind this proposal." I also attach an update message for all the people we support and our members. I feel duty-bound to reflect to them our understanding of their needs and the current circumstances, and I want them to know that we are engaged in this discussion. We would like to send this out as part of an automated schedule member update on Thursday PM. Therefore, an early indication that this is something that could be considered would be very helpful. I realise it would be too much to ask for any agreement in principle by this point, so any initial reactions, processes or information required, and indeed, if it were seen not to be possible, that would be very helpful. As always, happy to chat with you and relevant colleagues as required. The update referred to in this email can be found in page 1 of Alzheimer Scotland's inventory document 5. Despite this early indication and preparedness for us to attempt to alleviate some of these issues in order to avoid further trauma, we were only able to open up one centre by August 2020. This was a very small-scale initiative and had to be closed back down again when the measures were changed towards the end of the year. It was not until July 2021 that we managed to open up these services on a small scale across the country. It is normal that the highest proportion of most of the people who contact Alzheimer Scotland are family members and carers, and this was the case during the pandemic. This information comes to Alzheimer Scotland through many routes: our 24-hour free-phone dementia helpline, our national network of dementia advisors, our post-diagnostic support link workers, and others, all of whom continue to support people with dementia and their families throughout the pandemic, using mainly telephone and online support. A cause for concern for us was the decision-making processes becoming a blanket approach. An example would be, no one can do any daycare, no one can get into a hospital to someone, no one can access a care home. We were inundated by people with distress saying, "I can't go to hospital to see my mum or dad, and they are dying." Initially, we understood that it might not be able to enter a care home, but what we also were aware that there should be a better way of looking after those individuals with dementia and their families. For example, I wrote position statements saying any families denied access to a care home should be offered a named person. The named person would help them understand the logic and rationale and help them understand the changes to the guidance. We never thought it was fair to leave the care home manager to deal with all the families on their own.
Right. In that section, you quote from 2 emails where you put proposals to officials, both in April 2020. So the context of that is, again, very early in the pandemic, and you were making these proposals. In paragraph 54, you say that, in terms of the email, that you were asking that something could be considered. It would be very helpful. Was it considered? Do you know?
We didn't get a kind of a clear agreement in principle that it was going to be considered, or that we could feed that back to our members. I mean, what I know happened was it was put into these other groups and bodies that we described earlier, and it certainly was given some some consideration, but we didn't get what we wanted.
You also mentioned, and you've previously mentioned, the issue of a blanket approach in paragraph 58.
Yeah.
As you were progressing and your thinking was progressing, and the input that you were getting from your members and from the dementia cohort in Scotland, did you have doubts as to the wisdom of a blanket approach?
Yes, I think, Mr. Gale, to begin with, we, like many other people, didn't know exactly how to handle the situation and were guided by the information and advice that was coming through from the sciences, was often said, and indeed public health. By the summer, we were starting to say, this does not make sense, and the whole issue of a blanket ban, for example, on people going into hospital or not doing daycare, and perhaps, I mean, very significantly, without a shadow of a doubt, the care home situation with families not being able to visit, was a very blunt instrument to deal with very detailed human concerns. And I think it remained for far too long the standard approach to determining how we looked after people.
In that evolving approach that you were having, were you, either individually or as a group, an outlier in that, or do you know if others had were sharing the same views?
Well, I think there were others who were ahead of us on this and stronger, perhaps, you know, much quicker about this, and we certainly were very supportive of their right to be expressing these issues. I don't think we were necessarily an outlier. I think that within our community, the dementia community was probably alongside us, and the dementia community is much more than just Alzheimer Scotland. Yes. So there's many sort of elements to that where we've got deep connections, and that included our nationality, our professional consultants, and a lot of people with very considerable experience. What we were starting to hear more of was actually, you know, infection control systems, forms of barrier nursing. There are methodologies that could be utilised in a more specific and precise way that actually could probably have dealt with things as well as a blanket approach did.
I think we heard last week from 4 core members of the care home residents, relatives group, and they in particular made reference to an open letter that had been sent to Nursing Times. I think you're probably aware of this, signed by a number of infection control experts. Did you at that time share that approach that in some way infection control could be used properly and as an aid to allowing people into care homes to see their loved ones instead of a barrier to them going into care homes?
Our position on that was that, again, that we were starting to see an emerging understanding of a different view. And what we then asked of the decision-making process in public health was why are you saying that a care home has to close again or people can't access it? What's your evidence for that? And why does this other body of evidence not have any weight within this process? So we weren't taking a side. We weren't saying we're 100% on this side or 100% on that side. What we were trying to do was to understand what's the logic and rationale for your decisions, and why are these other matters not, you know, being given any weight. And I think that was, you know, perhaps at that time trying to be balanced, but really desperately keen to see issues like visiting be reinstated safely.
Did you receive, really from anybody, a rationale in support of a blanket approach as opposed to the more nuanced approach that you had obtained from, informed from your membership and indeed had experienced from other sources?
So we wrote to sort of public health when sort of some of these decisions were getting made, and we did on a few occasions get responses back just explaining what the guidance was. And I don't think we actually pushed much further on that, to be honest with you, Mr. Gale. We never got a complete detailed explanation as to why the blanket approach is the way that things were, and we started not to accept it, and we started to argue against it.
Mm-hmm. Yeah. Can you remember, just very generally, and I'm not asking you for a date, when you started to argue against it? When did you see that the force and perhaps the overwhelming force in the contrary view that you were propounding?
So we started arguing against blanket decisions in April 2020 when we were wanting to open up our day services, and we wanted a clearer opportunity to provide that respite support, and we continued with that. Where we probably, I think, started to get confident around about things like allowing people into care homes was towards the sort of like the later end of sort of November and December, where we had been really trying to make an argument that people don't understand the guidance and are not applying the guidance. People are not being supported, and you might wish to come on to it later, but we did write significant proposals about how we could support families better during that period of time. We called for a named person, and to be perfectly honest with you, I do not think it's unreasonable when you consider that all of these families were going through the most traumatic and stressful and difficult experience of their life, with one care home trying to look after 30 or 60 families on their own. That should have been an area where there was significant investment and support given to people, and at the very least a named contact to help them understand what was possible, what wasn't possible, what might be possible, and to push that forward, and to help the care home interpret the guidance and understand what is required. So at that point in time, we still weren't 100% certain, saying, yeah, absolutely, let's stop this and let's move towards a more nuanced approach. But we were beginning to get more confident. I think when the vaccinations came through, we were in probably no doubt that there was no need at that point in time for blanket approaches, and that it should all have been about individual agreements around about sort of like, the care home, the environment, and that's probably around the time when, Anne's Law was in, certainly from my perspective, something that should have been implemented.
And I think, I don't want to take you out of sequence, but at paragraph 92 in your statement, you indicate that you support Anne's Law. Yeah. However, that is also, you say, is also getting watered down a little by the government. We'll come to that in a moment. But at present, and going back to the late part of 2020, you were in support of Anne's Law.
I have to be honest with you, we were in support at that time of the need, our campaigning point at that point in time, which was a public statement that we made both in the media and to government, was that every person should have a named person. That was our most concerned point. We absolutely wanted to see people getting access in terms of visiting. We weren't expert enough to say that it could happen at that point in time safely, so we were balanced in our approach there. But towards the latter end of that year, we were absolutely definite that people needed to get access.
Okay. We go back to what you proposed at paragraph 60, and could you read on there, please?
As well as proposing to remobilise our day services, we also argued that there was more needed to be done and could be done to support families. There were thousands of workers in health and social care system, many on furlough, and we advocated that every family should have a named person. We got some hearing on that, but it did not go as far as I would have liked. We then wrote a proposal on that based on giving families greater support. This led to short-term funding of what we termed the Action and Rights team. And that team became an important part of helping families advocate and understand the guidance. We also put in proposals to the Scottish Government based on our frontline knowledge, and we received funding for small counselling service to help people facing loss and trauma. This was funded for 2 years and started in June 2021. We also proposed in 2021 a more fuller carer support programme, which was funded by the Scottish Government and commenced in early 2022. There were 3 elements to this, and given by this time our centres had started to reopen, we ran a series of on-the-ground support and respite for carers. We set up a dedicated carer space within our virtual resource centre, and we developed an innovative fund called Time for You, which provided carers with grants of up to £350 for personal and innovative respite. A good example of the Action and Rights team's work was with essential visit guidance, which was poorly understood. Our Action and Rights team were able to help people understand the guidance, and we would advocate on their behalf. We then started to work closely with other groups that had emerged, such as the care home relatives groups and others that wished to have visits to care homes. And what we campaigned for was that the support people needed to understand the guidance. We would tell people how to go about getting an essential visit, and we would advocate with the care home and say that this person meets the criteria and you need to allow that to happen. So we received funding for 6 months for the Action Rights team, and we now fund that from our own service funds. There were lots of people who were not receiving care from us, like many family carers. They couldn't get a visit to hospital or care home, so these people contacted the Action and Rights team, and we provided an advocacy service so people could understand their rights and essential visits. The documents we provided to the inquiry reflect what people with dementia and carers were telling us through the tens of thousands of interactions we had with them, through our frontline staff and volunteers during the pandemic. As we started to understand the guidance, we got more confident. We started to engage with people who knew about barrier nursing and proper techniques. We found that there were ways that things could have been done, and we started to get more challenging, asking why access was denied. We approached that in a far less public manner than the Care Home Relatives Group. We did that through the channels that we had with the Scottish Government, and I think that was the right position to take at that point in time. As things progressed, there was new evidence of the value of face masks, isolating people in their rooms and care homes, and things started to become less certain about the public health guidance. And what we saw was that as things opened up again, if there were any outbreaks, then care homes closed again, we would say why this cannot be the response. I personally felt that the public health concerns and focus remained for too long the driving force for decision making, and that impacted people in the most profound way. We had no influence at that point in the decisions that were being made. At the time we published our Hidden Impact report, our level of influence was nothing like it should have been. Our community was not a high priority, and I think the issue in care homes was being viewed through the lens of the care home sector, with PPE, staffing and visits being the main concern. What we were concerned about was that people were dying in these environments and they did not have access to their loved ones with no quality of life. And as part of our Fair Dementia Care campaign, we knew that many of these individuals were also paying for it. There were people dying of COVID in care homes, and some of them were paying £1,200 to £1,600 a week for that. I circulated communication saying that when these people die, you need to ask yourself if it is right for the family to receive a bill. This highlighted to me the inequality of people with advanced dementia in care homes being charged for their care, and we were deeply concerned about that. We also campaigned and argued for studies to look at antipsychotic medication, and antipsychotic medication started to get used in a way that we were concerned about. We were advocating that this should be studied, and there was some evidence the Scottish Government reported that there were increases in the use of medication.
Now, I'd like you to carry on reading from your statement, but after you've finished the section on care homes, I'd like to revisit 1 or 2 points. So if you would continue on to the end of paragraph 79, please.
The figures quoted in our Rule 8 response is that there are approximately 29,465 long-stay residents in care homes in Scotland, and that 18,500 having dementia. Evidence from research highlights the risk of COVID infection associated with the size of care home facilities, larger facilities posing a greater risk of outbreak among residents, including death. I think within the community, dementia was the most common pre-existing condition that people had when they died of COVID. What that told me was that people with dementia were really impacted. There would need to be a lot of research conducted to figure out why that was the case. When it came to care homes, what we were hearing was that people had to be isolated in their room and they had no social contact. The image of someone living with dementia is that of someone who's frail and elderly. A lot of people were active and wished to be involved in social activities. The therapeutic nature of a care home is important. Potentially what was happening was that 30 or 60 residents would have to live in their rooms. The consequences of that were that their mental health would be significantly affected by that, and unable to see relatives or having to see relatives through a window. If people living with dementia in care homes are faced with staff wearing a mask, that, in our opinion, would have an impact on their well-being. Someone living with dementia in advanced stages struggles to have a sense of time, place and person. When looking after someone with dementia, you need to help them with a sense of self and well-being, using reminiscence techniques, social stimulation, cognitive stimulation. And that is all mainly done in a care home on a group basis. The impact of COVID was that all that was taken away, and you could assume that the impact of that on people was hugely significant in terms of their abilities at that point in time. I would suspect that the levels of stress and distress would be higher, and how do you calm someone down in that situation if you don't have the non-pharmacological interventions to do that? For example, music therapy. The excess death reports that were eventually published demonstrated to us that being in a care home was a high-risk environment, not just because it was a shared environment, but how they had to react to the risks. There is no doubt that there was a lack of preparedness in care homes for having equipment such as PPE. Lots of things could have helped. One of the reasons for our long-term care commission is that what seems obvious is that people in small environments fare better during the pandemic. These smaller environments might have allowed for a more person-centred support to continue, but that was difficult within a larger environment. These smaller environments included care home and alternatives such as supported housing units. Care homes needed more staff who were properly equipped to provide that non-pharmacological intervention on a person-centred one-to-one basis. Care homes did not have that, and the consequences were that it had a direct impact on staff and individual residents. I believe in retrospect we should have found a way of making sure these families that wanted to visit were able to. They could have been managed into that environment and people helped and help people confined in their rooms. Families were desperate to get in. The situation was that families were outside windows, desperate to get in, staff who were in care homes already taking the risk and moving around and being in public, and finally people being in an environment in bubbles, not getting that much needed non-pharmacological family support. It would have been logical to find a way of getting that family member to enter and provide that. If that situation was to happen again, we would be advocating for families to enter in the safest way, just like anyone else entering that care home.
Okay, can I revisit a number of points that you've made in paragraph 60 onwards? Just one point I've been asked to raise with you. At paragraph 64, Mr. Simmons, you refer to the funding for the Action and Rights Team. What period, can you remember, did the Action and Rights Team operate on?
So we submitted 2 proposals around about the autumn period of 2020, right. And it wasn't submitted at that point in time under the name of the Action and Rights Team. It was later towards the perhaps early winter that we determined that term, and we received confirmation of that and put that team together around about February, March 21.
21, okay. And that lasted for 6 months?
It was funded by government for 6 months.
I'm sorry.
But we determined it was so important that we continued it. And during that 6-month period, it received about 113 referrals, and then since it's had about over 500 people that have been advocating and helping support to access visits.
Why was funding stopped?
To be fair, the agreement was basically a short-term response to the situation, and it was the proposal had a 3-month and a 6-month option, and we were content that it should continue with our own resources going forward.
Now, taking what you've said and what we proposed, and the sequence in which you've set this out in your statement, there appears to be, at least as I read it, a growing confidence in the view that you were taking that there should be a counter proposal and a counter view in relation to visiting, particularly in care homes and access to loved ones. You say that you became more confident. That's in paragraph 66. And then in paragraph 78, you say that I believe in retrospect we should have found a way of making sure those families that wanted to visit were able to do so. Do you feel in retrospect that you could have campaigned harder for this at an earlier stage?
I think not, given what knowledge we had at the time, what we wanted to do. And Mr. Gill, bear in mind that there was the option of an essential visit in the guidance. Mm-hmm. So what we wanted to do was to ensure that that was delivered, hence the action and rights team. So our perspective was that we actually are denying people access here when they had a right to it. And that wasn't well understood. And I'm sure many colleagues in the care home sector will tell you the guidance changed so often that it was very difficult to keep up with the guidance. So our first point and port of call was to get people the opportunities that were already there. And we were, I think, quite successful with that through the action rights team. We helped a lot of people move from not being able to visit to having an essential visit. Yeah. And I think that probably if I had known then what I know now, yeah, and absolutely we would be saying, look, this is not tolerable, you have to let people in. But at that point in time, we were working on the basis of the essential visits being there, and still there had been quite a substantial level of guidance and pressure determining that this blanket approach was the right way to go. And it has to be said that there was competing perspectives on this. So as a broad church organisation, there were other voices that were not as well organised or well developed that we had access to, who were as equally concerned about visiting taking place against the guidance of that time. So we are not a single focus campaign organisation. We're a rather broad church, and we had to balance up all of that. And you know, I'm not saying it was huge numbers, but there was significant numbers of people as equally concerned about getting this right from a different perspective. So our position was to drive forward on what people actually were able to access and ensure that they got that, and at the same time seek to influence the decision-making processes as best we could.
You're not a proselytiser, you're a pragmatist.
Yes, my Lord.
Yes, thank you, my Lord. While not, put another way, you are a broad church, but within that broad church, you and obviously a significant cohort of your colleagues had a particular view as to what was the correct approach.
I think where our expertise lies, Mr. Gill, is in the community environment. So we're not a care home provider. Yeah. We do have one small supported unit, the supported housing unit, but we were no experts, and we do have a lot of views on the care home sector, as you'll see from the rest of my statement, but we weren't confident and expert enough, in my view, to be doing anything other than that which we did, which was to use our expertise in understanding people, understanding what their experiences might be, and trying to give them the right help to work their way through this.
You phrase it in paragraph 79 that it would have been logical to find a way of getting that family member to enter and provide that. Now, obviously you're referring to care homes in that context. Yeah. What was the logic? you may have already told us this, and you may be repeating what you've already said, but could I just understand what the logic was for you?
I think by the time we reached that point in the conclusions, it would have been, the logic would have been that the family members could without a doubt have helped with the non-pharmacological support and intervention of people.
Yeah. Yeah.
They could have been part of the care team, Mr. Gill.
Yes. At paragraph 80, you deal with the impact on hospitals and care homes. Perhaps you could just read that through for us.
In respect of the impact on transferring patients from hospital to care home settings, I've mentioned this within the Rule 8 response to the inquiry. I believe that the Mental Welfare Commission for Scotland looked carefully at this also. There were several measures and emergency legislation that were put in place to enable that transition. The facts were that those individuals were not tested prior to going into care homes or other environments more than likely had an impact. I can make a well-informed assumption that someone who had not been tested coming out of hospital where they could have developed COVID was undoubtedly a mistake. We were concerned and remain concerned that people who are in hospital in the normal course of events should return home when they are being discharged. The issue was that patients were being moved from a hospital to a care home instead of returning home, most likely as community services had been closed. These individuals and their families have a double detriment. They were denied the right to return home and denied the right to community care services. The points I was making in June 2020 was to provide support for carers of those people who were in care homes. We were advocating that people should have access to a named person. Each care home could have been given a team of 4 or 5 staff to look after families and be there to support them. That was our argument and how this could be done. Instead of that, it was left to the care home manager to do that work or a staff member trying to make sense of complex guidance. If more had been done, then it would have been easier for people to understand why they couldn't visit a care home and when they could visit, how to do that safely. Our proposal for the creation of our action and rights teams and our counselling services should have been considered much earlier and been much bigger. We were pushing for the rights, care needs and emotional support of families family carers to be much higher up the priority order. We were also looking for essential visits to be delivered where and when possible. The Care Home Relatives Group were running a big campaign and doing a fantastic job. And as the vaccination was introduced, we were much clearer that people should have essential visiting rights. And I think how the government started working directly with the Care Home Relatives Group and involved them in policies was a positive move. We were doing everything we could to make sure that the needs of carers would be respected. And once we had the action and rights team in place, the Care Home Relatives Group started to utilise that and we built a stronger relationship.
Can I just pause there? And it's really just on one point that I'd like your view, because it's something you have mentioned on a number of occasions, and that is guidance. And I think you've said on a number of occasions, you prefaced that with confused. Mm-hmm. Can you just give a little context to that, how you felt that was an obvious problem?
Yeah, I think, Mr. Gill, I think to contextualise that, what seemed to happen in terms of the care home environment was that what you had was a number of the perhaps very skilled care home operators running their services then faced with the pandemic. And they then were brought into this arena where every step of their actions was being determined by guidance, which was changing on a frequent basis. They were also then subjected to different forms of scrutiny beyond just the regular care inspection, to health boards taking some responsibility over care homes, and quite a sort of wraparound sort of focus into the care home, which was then about implementing the guidance as quickly and immediately in some cases. But what we were aware was that the group that was developing the guidance we had members of our staff that would have been part of that CPAG group offering some advice, but as the guidance changed, it often would be put out late in the day with an expectation of it being implemented the next day, and a general level of, I think, an unnecessary level of stress around about that care home having to respond to that almost immediately. And the care home staff are trying their best to deal with many, many people with not very much support, and many, many families want to come in and visit without much support. And I feel that as a community, we should have provided much more support around about the care homes, not just left it to the care home staff, but brought in teams to help the care homes understand the guidance, not just ensure they enforced the guidance, but understood it, and help families understand it. And that's where our named person argument sort of really sat and was formed around, Mr. Gill.
Thank you. Right, you conclude your statement with a section on lessons learned. Now, again, I'd like you to read through that, and then I'd like to pick up one or two points from it with you.
So, we have a care home estate built not by a commission or design process. It was built in the early 1990s by entrepreneurial investors who built up this network of some 1,000 care homes in Scotland. In the early days, these people were trying to make substantial wealth and investments, and it was funded through the Department for Work and Pensions. So care homes at that time were viewed in a different way, and many people were making choices about going to live in that type of environment. Over the decades, the nature of care homes has dramatically changed to such an extent that they became not a care home but an extension of hospitals to look after people with complex needs. There are also issues about how these are funded and supported. The flaw we will make if we do not look at that estate after COVID will be that we will just have to live and accept what happened in care homes. What we need to do, in my view, is build a new approach. Design an approach to long-term care that will have the ability to manage pandemics in a way that we never find ourselves in that position again. We need to rebuild and redesign care homes. They should be able to cope with a pandemic, and if there is a future pandemic, they should be built in such a way that you can isolate individual parts of the home to make sure people are not denied access to visits. Recommission the whole approach. As a society, we must look at the number of people who died in care homes with dementia. The excess deaths within these settings was huge, a person and a family behind every number. Another pandemic is going to come, and if we rely on large-scale environments to look after people with dementia and just make sure there's PPE, that is not good enough. There should be a task force redesigning care homes, making them COVID safe, and to make sure all these rights are protected. We also support Anne's Law, however, that is also getting watered down a little more by the government. Everyone has been affected by the impact of the pandemic. However, when you look at the experience of someone that has significant dementia and cognitive impairment, trying to understand a pandemic and the pressure that their family is under, then that is so much more difficult, and dementia just got lost. What we now know through facts and figures was that dementia was one of the most significantly impacted communities and the most significant comorbid condition in terms of all deaths. There are only 4 drugs available for people with dementia. What they do is alleviate some of the symptoms. They do not treat the disease. Everything about supporting someone with dementia is personal. It's face-to-face, community-based support and using non-pharmacological therapies. To take that away again would be horrific. We've noticed a huge lag in our community coming back out, and some of our resource centres are not being utilised to the same extent as they were prior to the pandemic. And I think there is still an enormous pressure on carers. We kept the action and rights team going, but we're actually going to quadruple the size of this as people need a lot of support and help. Our dementia advisor structure was localised, so moving forward we'll bring some of this service into the centre. This will allow us to give people an immediate response where we can. There are people out there who can't access an assessment and are in distress. It's like the tsunami that was created in terms of the pandemic then led to a dam. And that dam is sitting there with all these people backed up behind it, and our helpline calls are still phenomenal. We have a very direct experience of who we support, but we also have a duty to represent those that we don't support and the quieter voices. And that transfers into our campaign works. We also need better data, as at present there are people waiting for 12 months for a diagnosis. There's a broader debate ongoing with government about fair dementia care and charging policies, and we have a legal argument ongoing that people were being denied access to reassessment of their need when their needs change. That is with the Scottish Government just now.
And in conclusion, you indicate that your belief is that the facts stated in the statement are true and that you're aware that this will, together with the evidence you've given today, form part of the record of the inquiry.
Yes, Mr. Chair.
Just a few points from that final section, Mr. Simmons. One of the final points in paragraph 98, you say we also need better data. Data about what?
Well, it would be helpful if we knew exactly how many people were diagnosed and had dementia at the present time. We lack that type of data. I think that we don't know that just now. So everything we are doing in terms of the number of people with dementia is based on estimates as opposed to factual data. I think we could also be doing with data in terms of transfer and exchange, so data between NHS to care homes and social care, that there is much work to be done in terms of data.
And is that something that you feel your organisation could usefully input into?
Well, yes, and we've always done quite a bit of work applying the various sort of like methodologies to work out figures. So there's things like Eurocode and different approaches, and to be honest with you, you could apply 2 or 3 different models and end up with numbers that vary between 10 and 20,000. And we just, you know, we're just a wee bit in the dark on this, and we've recommended that we must look at that alongside that broader argument about the fact that, I mean, we can estimate how many people are developing dementia. You would then think that you would consider how you commission a long-term care environment, particularly how many care homes you would require, how many places you would need, and that you would commission subsequent services based on that information. One of our big failings is we don't have that, and we don't strategically commission the state of long-term care. That emerges mainly through private sector investment based on sort of market forces and philosophy. And that is where I suspect that if you've got the right type of data and you flow that into strategy, then you would sort of probably commission things in a different way.
Thank you. What you said, paragraph 88 and 89 is also very interesting, and you conclude at 89 by saying we need to rebuild and redesign care homes. You mean that physically? Yes.
Yeah, I think that Mr. Gill, the view we have coming through this is that there is some evidence that suggests that it's the large-scale environment that's perhaps the most risky one to be in. Yeah. Now, as I mentioned a moment or two ago, that environment hasn't been specifically designed or commissioned based on what we know to be the needs of our population. It's been determined by investors and the main investors. Some local authorities do commission their own and develop their own services, but it's been designed in a way that it's the investors and owners from that private sector that have built up our whole long-term care estate. Now, they will be experiencing significant pressures in terms of being viable, and we're already seeing many care homes not able to sustain the current challenges that they're facing financially. But what's also important to understand is that many individuals that are actually self-funding these environments to quite considerable sums. And what actually we would argue is that we need to just take a pause and think really carefully about how we design and fund and invest in this going forward. Now, I feel that the opportunity, if there are any opportunities through the new National Care Service, would be to take a very detailed, close look at what happened during this pandemic, to mitigate and rule out all the potential risks of scale and start to design an alternative approach to long-term care for people with dementia. Now, that is not impossible, but it needs a very high level of commitment, and it will need substantial resource. Now, our Long-Term Care Commission, we hope, will produce some starting discussions and some solutions for that. We certainly won't be the implementers of it, but we feel that as a society, to step back from this and not seek to transform these environments, both physically and from a financial perspective, and not to commission and think more strategically about this, it would be a huge mistake.
And I think the point you make in paragraph 91 is that, in your view, there should be a task force redesigning care homes, making them COVID safe, to make sure that all these rights are protected. If we are looking, Mr. Simmons, as indeed this inquiry will be, at certain recommendations, would it be your view that a sensible recommendation would be something along those lines?
I think so, Mr. Gill, and I think, what I would want to say is I think that, as I mentioned earlier, a lot of pressure was put on our care home providers and staff who were doing a really powerful and fantastic job in amidst very difficult circumstances. So this is not a criticism of them in any shape or form, but I do think that a system that relies on economy of scales to make it viable, when that economy of scale is actually the greatest risk factor of COVID and the pandemic, somewhere in the middle of that, I think you have to have a really clear and honest position and say that's not right. We need to look at this now. We've got 1,000 care homes. I'm not suggesting for a minute that we start closing care homes, but over time, right now, we should be designing and building and commissioning things, and that should be led by a strategic approach to commissioning, not left to the market. So we should be, as a sort of, a new national care service or as a local health and social care partnership, determining through good quality data what we think we will need and commissioning that in a way that is much, much safer and entirely different from what we probably have at the present time. If we don't do that, then we're just leaving ourselves open to exactly the same risks, the same likelihood of sort of like potential excess deaths from people with dementia in a way that is entirely wrong, in my opinion.
Thank you.
Can I just pick you up on those last two answers you've made? I understand exactly what you're saying. In the very broadest, most generalisation, or the very broadest generalisation, the estates, the 1,000 care homes, or however many they are, have been designed with a different purpose in mind. And that has been shown by the pandemic on the basis of your evidence to be inadequate. And I think it was in paragraph 89. Can we just go back to paragraph 89? Whoever's controlling it, scroll up. You say, they should be built in such a way that you can isolate individual parts of the home to make sure they're not denied access. So there's a design issue. And you've also indicated that perhaps smaller units rather than larger units would be better. And then in paragraph, was it the task force one, 91, there should be a task force redesigning, and you've elaborated upon that very clearly and cogently. Plainly, this inquiry is concerned with if there are any recommendations about these matters. Another way of approaching the same problem might be a regulatory regime, because one could, through regulation, provide criteria which require to be fulfilled in relation to care homes, smaller, separate units and so forth and so on. Would you accept that as an alternative that could be considered?
I think, my Lord, the current guidance from the Care Inspectorate is moving towards that very nature of advice. And I think that's also slightly problematic because
what policy is.
Yes, but what you're actually so what you're relying on then is that it's this point of, so you might have the sector that owns a large estate of care homes based on economy of scale getting new guidance to really transform the nature of that, and the difficulty might be that as you go smaller, your costs go higher,
no doubt,
and affordability become so this is where I think that it cannot be left to the market to determine the future of the long-term care estate. It has to be determined by investment
Well,
and strategy and commission.
With respect, a tendentious point in that others might have different views in relation to that, which might be, for example, regulation, as I suggested.
Yes,
Yeah,
yeah.
That's fair enough.
Absolutely.
Yes, Mr. Gill.
Thank you, Lord. Just two other points, Mr. Simmons. In paragraph 92, you've indicated your support for Anne's law, but you caveat that by saying that it is being watered down a little. Obviously, you know what Anne's law is, and you know what Clause 40 of the bill provides. What would you suggest?
I think it should just be enacted as a separate piece of legislation, just to move forward. It shouldn't be left to secondary legislation. So I think that the case is well made now in the position we're in just now. It should become law.
Thank you. Finally, paragraph 93, you express the view that dementia just got lost. Lost by whom?
Well, as I sort of explained, that what seemed to happen and should have happened, in my opinion, was that dementia, given the evidence that we've got in terms of the number of people who died with dementia, the excess deaths that were there, the experiences that we've outlined, we never really got a clear pathway through from, the diagnosis, to post-diagnostic support, to integrated care, to advanced care, and around that, all the hospital and care home experiences. We should have had a directorate, in my opinion, running that and dealing across the various other issues. What happened was that it was sort of any particular focus might be on, say, for example, the care home visiting. That wasn't dealing with dementia, that was dealing with a specific issue. Although people might feel that was dealing with dementia, it wasn't. And that's what seemed to happen, was that we got into dealing with that particular bit of guidance or this particular piece of guidance, and it was moving at a sort of rapid pace. And my view is that actually we should have been sitting looking at how, from the very earliest point of diagnosis to advanced stage dementia, we were going to look after people during this pandemic and doing that going forward. So when I say it got lost, the strategy of and a vision of how we tackle this and go through it just was not there in the sense that I describe it. So,
Mr. Simmons, I'm very grateful to you, as is the inquiry generally, for the information you've given us. I would ask you, is there anything that you feel you haven't said or that you would like to say at the end of your time giving evidence?
I think that the one area that I didn't really touch on that I perhaps should have done was perhaps the hospital-based experience of people. Mm-hmm. And we spent a lot of time talking about the care home environment. There were as difficult experiences for people going into hospital, and I think it would be remiss of me not to mention that, Mr. Gill. And I feel that we had made some very good progress in Scotland tackling the problem of dementia within acute hospitals or general hospitals. We had 10 care actions, we had dementia champions, we had consultants, nurses and AHPs that we were jointly funding with Scottish Government to improve that whole arena. And probably our experience now of that is that we've lost significant ground. And it is an area that I on reflection, think the inquiry will obviously consider and look at, but the experiences of people with dementia going through hospitals at the height of the pandemic and thereafter has been very challenging.
Just so that I understand that, how do you feel that ground has been lost in that context? So
what we had previously was a sort of high-level commitment to what was called 10 care actions. We had substantial investments in a programme called Promoting Excellence, which is a training framework for people so that everyone in an acute, or everyone in the health service and social care would have the right level of dementia-skilled training to do their job. And we also had a Champions programme, which was a sort of like a really detailed course of study that helped someone understand dementia and apply improvements within the hospital environment. We also had what was called the Focus on Dementia team, which was a big Health Improvement Scotland project, all looking at improving hospital care. That seems to all have stalled, Mr. Gill.
Mr. Simmons, I'm very grateful to you. Thank you very much indeed.
Thank you.
Yes, thank you, Mr. Simmons. You've obviously taken great care in the preparation of your statement and your evidence, and I'm very grateful for the way you gave it this morning. It was very helpful. Thank you.
Well, thank you.
Yes, 2 o'clock. Thank you.
Good morning.